Hi, my name is Adil Elias. On behalf of my co-authors, I'll be going over the salient points regarding the management of blunt cerebrovascular injury. The first point is that blunt cerebrovascular injury differs from traumatic and spontaneous injury in several ways. Regarding pathophysiology, patients with spontaneous injuries typically have an underlying connective tissue disorder, which is absent in most patients with blunt injury. In addition, the majority of blunt injuries are incidentally discovered during protocolized workup of otherwise asymptomatic traumatically injured patients. Most blunt trauma patients experience a hypercoagulable state, the timing of which overlaps with that of ischemic stroke caused by endothelial disruptions in the setting of blunt injury. The presence of polytrauma in patients with blunt injuries not only complicates antithrombotic management strategies, but also creates difficulty in recognizing ischemic stroke. These factors make the management of blunt injuries more challenging than spontaneous injuries. The incidence of blunt injury is about 1%. Motor vehicle accidents occur for more than half of cases. Other common causes include assault, pedestrians struck by vehicles, falls, and hanging. This figure illustrates the patterns associated with blunt cerebrovascular injury. Panel A depicts intimal injury without formation of a thrombus. Panel B demonstrates intimal injury resulting in exposure of endothelial collagen, which activates platelets and forms a thrombus. This can result in thromboembolic strokes, which is the most common mechanism of stroke after blunt cerebrovascular injury. Panel C illustrates a traumatic aneurysm. Sometimes passage of blood underneath the intimal tear can result in vessel wall dissection, creating a significant luminal stenosis. Panel D illustrates a subintimal hematoma, which can also cause luminal narrowing. A significant number of ischemic strokes after blunt cerebrovascular injury occur before a treatment can be initiated. This is data from our center showing the time from admission to CT angiogram in about 70 consecutive patients with blunt trauma. Of these patients, 6 had strokes and the mean time to diagnosis was about 4 hours. In another multi-center study of patients with blunt cerebrovascular injury and stroke, the stroke was present on admission in 1/3 of patients, and the majority of remaining strokes occurred within 72 hours of admission. These findings support efforts for early diagnosis through screening protocols and prompt initiation of antithrombotic medication in an effort to mitigate ischemic complications of blunt cerebrovascular injury. Based on several screening criteria, risk factors for blunt cerebrovascular injury include a cervical spine fracture, a closed head injury with poor GCS, petrous bone fracture, and Lefort 2 or 3 fractures. However, 20% of blunt cerebrovascular injury occurs in patients without any of the reference risk factors. Given that the majority of patients with blunt traumatic injury are asymptomatic, that strokes generally occur within 72 hours in these patients, and that technological improvements have allowed for high-quality, non-invasive imaging, we recommend universal screening with a CT angiogram of the neck of all patients who present after blunt trauma. Compared to a diagnostic cerebral angiogram, a CT angiogram has good sensitivity and specificity in detecting cerebrovascular injury. Patients with unilateral vertebral artery occlusion have about a 20% risk of stroke. Those with bilateral occlusions of the vertebral artery have a 50% risk of stroke, and patients with a unilateral carotid artery occlusion have over a 50% risk of stroke. Antithrombotic medication is a cornerstone of therapy for blunt cerebrovascular injury. We recommend a baby aspirin or 81 milligram aspirin daily. In our study, we found that a full dose or 325 milligram aspirin regimen is associated with an increased risk for a blood transfusion. So at our center, asymptomatic traumatically injured patients with blunt cerebrovascular injury are routinely placed on a daily regimen of aspirin 81 milligrams unless contraindicated. All patients with convincing CT angio evidence of blunt cerebrovascular injury should undergo observation and regular neurologic examinations during the hospital admission, particularly during the 72-hour period after injury, at which the risk of thromboembolic stroke is greatest. The patients at greatest risk for stroke, such as those with complete ICA or vertebral artery occlusion, merit admission to the neurosciences ICU or a unit capable of hourly neurologic checks. Endovascular options include diagnostic angiography, stenting, embolization of traumatic aneurysms, intraarterial thrombolysis, and endovascular vessel occlusion. Despite growing use of endovascular techniques for the treatment of blunt cerebrovascular injury, it is important to consider potential drawbacks, such as the need of dual antiplatelet therapy with stent placement, which can be problematic for patients with polytrauma, particularly those with intracranial hemorrhage and those requiring other surgeries. Therefore, the use of stenting procedures in trauma patients must be individualized and only performed after consultation with all surgical services involved in the care of the patient. We reserve endovascular treatment for traumatic aneurysms for lesions that demonstrate significant enlargement on follow-up imaging. So let's conclude with a couple of cases. The first one took place before the implementation of our universal screening protocol with CTAs of the neck in patients who present with blunt injury. 33-year-old female was hit by an oncoming vehicle, and upon her admission, a CTA of her neck was not performed because she did not meet screening criteria, and also we at that time had not implemented our universal screening protocol with CTAs of the neck. Within 72 hours of admission, she developed left upper extremity weakness, was found to have a stroke. A diagnostic cerebral angiogram demonstrated right ICA dissection. She was placed on a full dose aspirin and was maintained on that and did not have any worsening of her symptoms, no new neurologic deficits. 10-month follow-up in clinic with a CTA of the neck demonstrated a right ICA aneurysm measuring about 16 millimeters, and another follow-up CTA in about 5 years from her injury demonstrated improvement in the size of this aneurysm. It had decreased to 8 millimeters. So again, this highlights the importance of antithrombotic medication in the management of blunt cerebrovascular injury. It also highlights the importance of our universal screening protocol, CTAs of the neck in patients with blunt cerebrovascular injury. Let's move on to another case. A 17-year-old female presented after a motor vehicle accident. She sustained a cervical transverse process fracture. A CT angiogram of her neck revealed bilateral internal carotid artery dissections. She underwent a diagnostic cerebral angiogram to further evaluate these dissections, which looked suspicious. Indeed, on angiogram, she was found to have bilateral ICA traumatic aneurysms just below the skull base. So she was placed on a full dose aspirin, and she remained symptom free after her injury and was followed up in 14 months. At that time, a CT angiogram of her neck demonstrated no change in the morphology of the aneurysms. However, there was some lengthening. She was maintained on the aspirin dose and remained on that full dose aspirin dose and remained symptom free. Again, this case highlights the importance of antithrombotic medication, particularly aspirin, in the management of blunt cerebrovascular injury, and the importance of reserving endovascular therapy for specific cases. This was an overview of the salient points in the management of blunt cerebrovascular injury. Further details can be found in the book chapter. Thank you for your time.